Hello, my name is Katharina Haag and I'm presenting to you today on the mental health of women aged 45 to 60 living with HIV in England, a Latent class analysis of the PRIME study. As a background, women living with HIV are at a higher risk of poor mental health outcomes, both than women in the general population, but also than men living with HIV. Due to recent treatment advances, more women with HIV are reaching menopausal age and are accessing care, so it's important to know more about their needs. Menopause has been found to encompass a range of changes, hormonal, psychological, social, that can affect women's well-being, but there is limited literature on the mental health of women living with HIV during menopause, and especially how menopause and mental health difficulties might interact. It's also not clear if there might be groups of women at particular risk of poor outcomes, both in terms of mental health and clinically, and identifying them could help to improve screening and care. Our aims for the study were firstly to derive groups of women with similar types of mental health symptoms from a sample of women presenting for HIV care in the UK, and to see if these groups differed in terms of their demographic characteristics, so ethnicity, poverty, time since HIV diagnosis, education and menopause status, and their clinical outcomes, including last HIV viral load, CD4 count, and engagement in care. We used data from the PRIME Positive Transition Through Menopause study of 869 women aged 45 to 60, so in menopausal age, who were accessing HIV care at 21 clinics across England. These women self-reported on a range of measures, including on 8 mental health indicators, which comprised lifetime diagnosis of depression and anxiety in the past 2 weeks, risky drinking, if they were a current smoker, if they had used recreational drugs in the past 3 months, if they had sleep problems in the past month, and if they suffered from severe psychological menopause symptoms in the past 2 weeks. And this measure both comprised a somewhat different assessment of anxiety and depression in the PHQ-4, also a dimension of irritability, and these questions were asked in the context of general questions about the menopause. So the overlap of this measure with the other measures was actually somewhat low, which is why we decided to include it as an additional predictor. We used the information provided by the women to perform a latent class analysis, which basically uses statistical criteria to subdivide a sample, in this case into groups of women with similar types of mental health problems. So there might be women more likely to engage in substance use, while another group could be more likely to be depressed. Once we had identified our groups, we used multinomial logistic regression to see if they differed in terms of demographic characteristics, and Waltz tests to see if they differed in terms of their clinical outcomes. Descriptively, the median age of our sample was 49 years. The majority of women was Black African, with somewhat smaller groups of white and Black other women, and 6.1% comprised different other ethnicities. Menopause status was provided from women's own ratings of their menstrual history, with 20.9% being classified as pre, 44% as peri, and 35.1% as postmenopausal. Clinically, most women were on ARTs, though 11.9% had a last detectable viral load, 21.4% showed suboptimal adherence in the past 7 days, so missed pills, and 10% had missed one or more clinic appointments in the past year. Mental health related, about a third had received a lifetime diagnosis of depression, a fourth each suffered from current depression and anxiety. There was actually substantial overlap between these two groups of women. Substance use was somewhat lower, with 2.5% using recreational drugs, 8.6% each being risky drinkers and current smokers. 26.5% had poor sleep in the past month, and 28.6% severe psychological menopause symptoms. And for the last two measures, rates were somewhat higher in women in peri and postmenopausal as compared to premenopausal states. As I said, we performed latent class analysis to determine groups of women with similar types of mental health symptoms in our sample. And we used the statistical criteria shown in the grey box below, in case you are familiar with the procedure, otherwise you can ignore it. And we found 5 groups of women in our sample. On the left, you can see a figure which on the outside has our 8 mental health difficulties, and then in different colors shows the likelihood for each class to endorse each condition. Class 1 in light green is actually almost not visible except for a blob in the very middle, because these women overall indicated few mental health symptoms. And this was the majority of women in this group, 57.8%. Class 2 in yellow, 13.8%, mostly suffered from high current anxiety and depression. Class 3 in dark red, 4.6%, were somewhat more likely to have a lifetime diagnosis of depression, very likely to be smokers, and more likely than other classes to endorse in substance use. Class 4 in green, 9.3% of the sample, again somewhat likely to have lifetime diagnosis of depression and severe psychological menopause symptoms and sleep difficulties, so more menopause-related difficulties. And finally, class 5 in brown, which comprised 14.4% of the sample, were very likely to have a lifetime diagnosis of depression, current anxiety and depression, menopause-related difficulties, but not necessarily as likely to endorse substance use. We wanted to see if these groups that we found differed in terms of demographics, and we found that compared to the baseline class of very few mental health symptoms, all other 4 classes had lower odds of having enough money for their basic needs. Classes 3, 4, and 5 had lower odds of having university education. Classes 4 and 5 had a longer time since the HIV diagnosis. Compared to a white baseline group, Black African women were less likely to be in classes 3, 4, and 5, and this was mainly because they were less likely to have been diagnosed with depression throughout their lifetime, but they also indicated lower rates of substance use and menopause symptoms. Black other women were also less likely to be in class 3 due to lower rates of substance use. Interestingly, all ethnicities but white had higher odds ratios to be in class 2, but very large confidence intervals, as you can see, and this was mainly because there were almost no white women in this class, which made the class comparisons somewhat less reliable. But follow-up analysis showed that this class might be particularly relevant for women of non-white ethnicity. Finally, women in peri- and postmenopausal stage, as compared to premenopausal stage, were more likely to be in class 5, so the class with difficulties across a range of indices. Regarding clinical outcomes, you can see here the probability for each class to have each of the clinical outcomes. We did not find class differences in terms of last detectable viral load or CD4 count. However, classes 3, 4, and 5 were more likely, compared to class 1, to show suboptimal ART adherence in the past 7 days. And you can see a gradient between those classes. Class 2 actually also has somewhat high rates, but they had quite large confidence intervals due to high variability within this class. So we could make less reliable predictions for this class, unfortunately. We also found that class 5 was more likely to have missed one or more clinic appointments as compared to class 1. And again, class 2, somewhat higher rates, but large confidence intervals, so the predictions weren't as reliable. In sum, most women presenting for HIV care at UK clinics actually had few mental health symptoms, 57.8%, but we did identify 4 additional groups with different types of mental health difficulties. And this is important not only for screening, but because these difficulties could be addressed through specialized treatment. In terms of cohorts, poverty, poor education, a longer time since diagnosis were associated with higher likelihoods to be in one of the groups with mental health difficulties, which again is relevant for screening. For ethnicity, the associations are a bit more complex, with Black women being less likely to be diagnosed with depression throughout their lifetime, less likely to indicate substance use and menopause symptoms. So in this group particularly, it could be important to screen for current symptoms of depression and anxiety. Menopause status did predict membership of class 5, so the class with more overall difficulties. So there does seem to be some kind of relationship, at least between menopause and well-being. Regarding clinical outcomes, all the groups with mental health symptoms seem to show somewhat poorer engagement in care, though no difference to class 1 in terms of viral load. Particularly group 5 seemed to struggle the most, which isn't surprising given that it had problems across a range of indicators. Of interest, groups 4 and 5 actually showed an overlap between more traditional mental health indicators around anxiety and depression and more menopause-related symptoms related to sleep and irritability. So we were wondering if there might be syndemic effects between menopause and mental health that could lead to the poor engagement in care. but longitudinal data will be needed to follow this up. In conclusion, we think it's very important to screen for menopausal status in all women presenting for HIV care, but especially those with mental health issues, as there might be compounding, as we've shown. Addressing menopause symptoms, for instance through hormone replacement therapy, could be key for improving well-being and HIV outcomes, especially in risk group, but also in women in general. I would like to thank our funders, the PRIME Study Expert Advisory Group, recruitment sites, and especially our participants. Thank you very much for your attention.